We have a very unique, interesting case today. This gentleman's from Los Angeles. I've known him for a very long time. He underwent this surgery at an outside facility. Great job on the surgery, but unfortunately he developed postoperative facet pain and radiculitis, and he was treated by his index surgeon with a hemilaminectomy, neurolysis, facet debridement, and that helped for a little while. And then he had recurrence of his pain, and he came back to see me well over 5 years ago, maybe close to 10 years ago. And I did an endoscopic foraminotomy, neurolysis, facet debridement. He did well for many, many years, and his pain has come back. Obviously, we're considering doing a fusion, but that is a big deal. Most fusions require that this implant is taken out, and that is a life-threatening magnitude surgery. So if we can get by with just intermittently treating this facet-mediated pain, that's our strategy. He also has sacroiliac joint pain on the other side. In any case, very interesting case. The surgery is designed to do basically a good rhizotomy of the facet joint, as well as debriding any kind of epidural scar tissue that is causing the nerve to be adherent. Because remember, whenever we bend over or straighten out our leg, the nerve slides almost a centimeter in a normal situation. So any nerves that are scarred and tethered down, they will be painful just by moving your leg out or bending forward and putting a stretch. That's the equivalent of a straight leg raise. During the surgery with the laser endoscopic technique, he'll literally get a Band-Aid. He'll be back to activities very soon, and hopefully this will work again to provide him another few years of relief. Tons and tons of inflammation. That should not be a disc, since we have a disc replacement, but that's the back of the disc. Look at all this painful granulation tissue. You poor thing. Look at all this scar tissue. Usually this just falls in and I can get right into the canal and get around the pedicle. But not when there's inflammation, and look at all these blood vessels. I think you're going to feel a lot better. So I'm going to release the nerves from all this adhesion, and then I'm going to go up above and get rid of the facet joint and do a rhizotomy. It's a lot more scar this time now compared to last time. Woo! Look at that.
Okay. So if there's a small enough piece, like pretty small. Yeah. Yeah, it's usually kind of off a little bit. So.
There it goes. X-ray. So, lots of scar tissue. I was able to clean all that up. I'm feeling good about that. I'm going to do the majority of the work up above at the facet joints. But there's a lot of inflammation down here. Theoretically, the posterior annulus can continue to cause pain because there's a lot of nerve fibers there. Ooh, that's where the exudator root is. Very scary. And that's Deborah saying, the nerve is awake. Stop messing with it. Can I have the Viagra now? That's the inferior edge. Look at how ugly and inflamed that looks. This is the lateral inferior edge of the facet joint. You can just see how unbelievably inflamed everything is. The facet joint capsule is way thickened compared to normal. And this is after the fourth time it's been debrided. Third or fourth time, I can't keep track anymore. But there it is. The laser will really work well in a second.
Thank
Thank you. This is the sci-fi laser. You can see how it's much more effective in vaporizing and making things disappear. But if I had a blood vessel, it will start to bleed. Whereas the Elman probe is electrical, it's not as effective at ablation, but it's really good at controlling bleeding. And the laser is way more fun to use inside. Sort of like a driver, is way more fun than a putter. But the most important plug in the bag is the putter. And that would be the Elman probe. Oh, I am liking that.
Yeah, small turning right foot on top.
So one good thing about the sci-fi laser is that I can undermine the multifidus as I go medial. And just stay in the posterior capsule layer. I'm not wanting to take a capsule up, I'm just wanting to do a radio frequency rhizotomy or a laser rhizotomy. And it's just that the capsule contains all that Takapuku nerve. I want to maintain the medial aspect of the posterior capsule so that there's some proprioceptive function as well. Woo, I like that. Seems like forever on my end.
Really?
My shoulder's killing me.
1.2, you put the local in.
Alrighty, here's the radiographic summary of the surgery. I start out with getting a perfect AP. And then in the lateral position, I first insert this really thin initial dilator called the spaghetti noodle dilator. That's not the official name, that's just my name, because otherwise you won't never remember what it is. And then you make it bigger, put the cannula in, move to the AP position, and as you operate, I start checking where I am all around. I need to get up and down and across. You just see me feeling around with that little probe. And then I'm on top of the facet right here. I don't know if you can see this facet shadow. So I basically debrided all of this across here like this. And there's a lot of inflammatory scar tissue. So I'm fully expecting that you get a lot better. So best wishes and happy holidays. We're all rooting for you.